Okay, we are ready. Okay. Buenos días, continuando con el programa de hoy. A nombre del señor embajador de la UNESCO, Jorge Herrera Ramos, y Chairman del World Congress of Neurosurgery, UNESCO ASMED Walter E. Dandy, in honor of Professor Yasahil, a quien agradecemos por la organización de este magno evento, así como a la doctora Deyanira Capi Casillas, Chairman del capítulo ANS IPN, al doctor Salim Abdurrauf, Chairman de Walter E. Neurosurgical Society, al doctor Babak Teb, Chairman de la Society for Brain Mapping and Therapeutics y The Brain Mapping Foundation, todos ellos vice-chairman del comité organizador, y al doctor Parmenides Guadarrama Ortiz, chairman del Centro Especializado de Neurocirugía y Neurociencias México. Es para mí un honor presentar la siguiente ponencia a cargo del doctor Salman Sharif, quien es presidente de Pakistan Society of Neurosurgeons, presidente de World Spine and Column Society, copresidente de Spine Committee of World Federation of Neurological Society, miembro del Comité de Endoscopía de World Federation of Neurological Society y miembro del Comité Ejecutivo de Educación de American Clinical Neurophysiology Society, quien nos hablará el día de hoy de curva de aprendizaje en cirugía de columna mínimamente invasiva. Doctora Natalie.
Yes, thank you, Dr. Rubalcaba. Hello, everyone. We are happy to welcome you again and thank you for joining us all this time, whatever you are in the world. So good morning, good afternoon, or good evening. We are happy to see you again in the World Congress of Neurosurgery in the cooperation of UNESCO and Walter Dandy Neurosurgical Society in honor of Professor Yasargil. My name is Natalia Fedorchenko, and I'm talking on behalf of the organizing committee and the chairman of the Congress, Mr. Jorge Herrera Ramos, also ambassador of peace of UNESCO. I would like to present to you also our honor committee, vice president of the World Congress of Neurosurgery, Dr. Deyanira Capi Casillas, president of WAPS Medical Students Chapter in Mexico, also Professor Salim Abdurrauf, World President and Global President of Dentist Society, and Vice President of the Congress, Dr. Babak Kateb, President of the Society for Brain Mapping and Therapeutics. Also, the honor committee is Professor Nasser El Gandour and Professor Marcus Rota. And we are grateful to the Dr. Parmenides Guadarrama Ortiz from the Instituto Politécnico Nacional from Mexico for taking part in putting all this stuff together, and for you guys from Mexico, from the ANS in Mexico for broadcasting and neurosurgical TV. So it is an honor for me today to be with you, and I would like to pass and give the next words to Professor Alvaro Cordoba, who gave us a great talk last week about the muslinoma after clipping the aneurysm. So today you have the great chance to introduce another prominent neurosurgeon. So we would be happy to hear from you, and you can continue the presentation.
Thank you so much. Thank you so much, Natalia. Thank you so much, everyone. It's a very, very high, very wide, huge pleasure to introduce Professor Salman Sharif, because not only is a very good friend of us, all of the neurosurgeons around the world, is a very, very important neurosurgeon in International Federation of Neuroendoscopy. Mainly in all of the aspects, we participate in a lot of several workshops around the world. He's a very, very good teacher, and it's very important to hear about his experience in spine minimally invasive approaches. So we are very proud to be part of this this morning, this part of this introduction. So Salman, will be a pleasure to hear you, and will be discussed after your talk all of the aspects and what happened perhaps of the results. Normally in spinal and minimal invasive, is it possible to compare with the open approaches, with the mini door approaches, and so on. Thank you so much, Salman, and we are very proud to be here.
Thank you, Alvaro. Thank you, Eka. Thank you, Nachari. I think, this is a brilliant organization, and I'm very happy to be part of it. Can you hear me okay? And can you see the slide okay?
Perfect, perfect.
Okay, brilliant. So this is a talk that I gave in one of our main meetings last year, and we have made some changes since then. I have written something about it, and I find it's very important for young neurosurgeons to know what are the problems that you're going to face when you start out doing minimally invasive surgery, and especially if you're doing a new procedure, how do we go about it? So I'm grateful to the World Congress for giving me this opportunity, and to our friends from all over the world, everybody around the world who's helped us in doing this over the many years. This is actually an area of northern Pakistan. If you don't know, then out of the top 15 peaks in the world, 6 are in Pakistan. And this is Fari Meadows, very close to K2, which is the second highest peak in the world, and it's near Nanga Parbat, which is the 5th highest peak in the world. Spine treatment milestones. Walter Dick back in 1984 and Kluger in 84 came up 30 years ago with this modern pedicle screws for patients at that time. And this was the first sign of screws that we put in. And we were thinking that all this is going to change the way we practice spine. Foley and Smith began the modern era of MIS with the description of tubular microendoscopic discectomy way back in 1997. MIS techniques since have been routinely applied to the full spectrum of the degenerative spinal condition, including herniated discs, stenosis, instability and spondylolisthesis, and deformity. What is the concept of surgery? To perform surgery, need to access a surgical target deep inside the body. Surgical path, approach is created, approached, that particular procedure or surgery is performed, and the path is closed. Despite following normal anatomical paths, surgeons destroy normal and functional tissues and leave scars behind, which is functionally inactive. So footprints are left behind just as we walk on a sand. So the concept of surgery, the basic principle is to effectively treat pathology with minimal disturbance of normal anatomy, leaving the smallest footprint. Minimally invasive surgery, minimal opening using natural planes, keyhole surgery, but performing the same procedure that you will perform when you're doing it open. Why you want to do MIS? So it's because there is minimal neural retraction. There's contralateral anatomy preservation if you're doing from one side. Obviously, shorter hospital stay, minimal requirement of analgesia because there's minimal postoperative pain, and earlier return to normal activity with an economic benefits. And all this has been proven, and aesthetic results, which are obviously better. And this has been proven over time in last 10 years. Economic benefits have recently been proven as well. And many people have shown that adjacent segment disease reduces if you cause less tissue destruction. What is a learning curve? The concept of learning curve was originally introduced in aircraft manufacturing in 1936 by T.P. Wright. He described a basic theory for costing the repetitive production of airplane assemblies. The term was introduced to medicine way back in the 80s when we started doing minimally invasive surgery. Can we define it? The simplest but reproducible method of defining a surgical learning curve is time taken, or the number of procedures an average surgeon needs to be able to perform a procedure independently with a reasonable outcome. So we want to identify an average surgeon. So it's very difficult to know. Everybody thinks they're a pretty good surgeon, but an average surgeon may not be able to do what you think anybody else, who's very good, is able to do. So your experience counts, your know-how counts, your anatomy counts. Factors affecting learning curves are manual dexterity of individual surgeon, whatever you're used to, your understanding of 3D anatomy, background knowledge of the anatomy, experience of the supporting surgical team. When you're starting out a new case, if your surgical team does not know that, then you will cause problems for yourself. How frequently you're performing that procedure. A new technology does not apply to all cases. So good judgment comes from experience, and experience, well, that comes from poor judgment. So I think it's important that you learn from your mistakes and from other people's mistakes, especially in medicine. Training on inanimate trainers and training and with animal tissue has been shown to facilitate the process of learning. And that's why we have all these hands-on workshops that we do all over the world trying to teach people how to do this. That's why we have all this YouTube channels and videos of various procedures that can help you see a procedure before you do it. And there are loads of simulators now. The presence of structured training schemes and mentoring are an important factors. And we know that in areas where their mentoring is not good or the structured training is not there, those people run into a lot of problems. The slope of a learning curve depends on the nature of the procedure. So learning curve for minimally invasive procedure is longer than for open procedure. However, studies have shown that when inexperienced subjects, i.e. residents, are given equal training in laparoscopy and open surgery, the overall skills acquired were similar by both methods, even for a senior surgeon or for a resident. So they were equal kind of results if they were trained in minimally invasive surgery. So this is actually very encouraging. So limitations, factors contributing to steep learning curve or a very, very high learning curve, because there are no clear anatomical landmarks. All those landmarks are radiological. So you're seeing image. So mystery attributed complications during a microendoscopic discectomy learning curve period, unfamiliarity with the endoscopic image orientation, and suboptimum approach to the surgical target. They thought they could see a big area, although with endoscopic discectomy, you're seeing only a 1.5 centimeter area. And if that is the case, then you may think that you're doing a big surgery, but it's all zoomed, it's all enlarged, and you may be not seeing enough. And then you may, because of that, you may cause injury to neurological structures, not knowing where they're going. Multiple durotomies were seen in the initial part of all these people. Wrong levels were operated because they were too busy thinking about, are they doing the right thing? And they were too busy teaching people around them how to do that. And unintended removal of facet joint structures because they didn't know where they were drilling for sure. So the key step in overcoming the MIS learning curve is an ideal entry point and trajectory during the surgical approach. So it could be endoscopic disc, it could be MIS screw insertion, it could be MIS TLIF, it could be endoscopic TLIF. Whatever you're doing, the first thing you need to do is make sure your trajectory is right. If the trajectory is right, your start is right, you know where exactly you're going, you are expecting what's going to come, then it makes it easy. So Park and Dahl and Howe, they asserted that I'm not sure I understand. That a correct initial placement of tubular dilator during the MIS TLIF approach prevents intraoperative readjustments. And we know very well, we have seen it many times, intraoperative readjustments done by anyone leads to higher rate of neurological injury and inadequate decompression. So how can we measure a learning curve? We can measure by patient's outcome or by clinical process or task efficiency. So common patient's outcome measures are incidence of complication and survival, and we can do that, it's fine. Statistically, it's more complicated. Hence, operating time and period of hospitalization are used in majority of the times when you're looking at the outcome. There is no ideal measurement of learning. Various proxies are used for measuring the learning process. While we agree on how to measure the learning curve, we cannot say how we should compare individuals' progress, particularly in dealing with real patients. So a patient who starts from here and his performance goes up and it comes to a degree of point B, so he's pretty reasonable. And then he comes to an asymptote where he's just static over time. When is this particular surgeon going to reach here? We really don't know, and it varies a lot. Damaged nerves, it was shown by Epstein way back in 2016 that damaged nerves are maybe because of smaller incision, and they don't necessarily mean better outcomes if the surgeon isn't familiar with the anatomy and exposure. And there is increased radiation exposure, huge amount. Recent studies suggest significant increased radiation with minimally invasive techniques. So this is important to understand from young surgeons' perspective, that you have your image intensifier and you have your X-ray tube. And all the scatter that's coming, so there's not much of scatter next to the image intensifier itself. All the scatter is way back from where the X-ray tube is. And the primary X-ray is emitted from the X-ray tube. And so what happens, you get all this scatter. So area below, you've got 2 to 3 times dose of the radiation, whereas area where you're standing and the area above, the scatter is much less. So you need to make sure there is enough distance between these two in order to understand that the scatter is going to be as less as possible. We know this, that we have to stand on the side of the image receptor and not on the side of X-ray tube, because there's all the scatter coming out from there. So it's, again, one important lesson that we must know in order to avoid a problem. And you need to wear proper protective gear. We also know this inverse square law applies with radiation. So what is it? That you're doubling your distance from X-ray source decreases your dose by a factor of 4. So it goes down by 1/4 if you go to 2 meters. If you go down to 3 meters, go down by 1 by 9. So if you continue to go like this, you're going to continue to reduce. So your staff, if they are in, even if they are protected, they need to wear proper gear and at the same time stand as far back as possible. So the recommendations by many people over time regarding fluoroscopy is avoid continuous fluoroscopy. As we said, distance between the patient's surface and the flat panel detector should be minimized. Beam collimation should be used whenever possible. The distance from radiation source and the patient surface as the origin of scatter should be maintained. That's what we showed earlier. Hands should not be in the path of the X-ray when we're holding an instrument. So instrument has to be far away. No staff member should stay in operating room when we're acquiring 3D scan, especially for intraoperative or CT or O-arm kind of thing. So what is an average learning curve? So our friend Paulo Pereira from Portugal looked into this, and they found that MI is correlated with a steep learning curve. Approximately 40 cases were required to come up with a learning curve. Half of the improvement can be accomplished by 12 cases, and 90% of the expert's proficiency level was achieved around 40 cases. So this is for MIS TLIF that we're looking at. So this study clearly showed that there were 150 cases, an average OR time, 140 minutes, 50% learning curve, and 90%, 39 cases. And they showed that the overall complications, dural tear, everything reduced in the second set of patients who were operated. What about microendoscopic discectomy for lumbar disc herniation? So 873 consecutive cases. And if you look at early group versus late group, operative time 75 minutes in initial, 49 minutes in the late group. And blood loss 72 mils, and which goes down to 35 mils in the late group. And we can see the rest of the things were significant as well. The total complications, all that were reduced. What about learning curve with microscopic assisted tubular microsurgery for 1 or 2 level? So if you look at this, these guys looked at their outcome over the years. So 2004 to 2007, and they showed that the problems that they were associated and their time, etc. So mean operative time, you can clearly see continues to go down. And in 1 level and 2 level, so both for laminectomy as well as for microdiscectomy. Failure is inevitable. We are built to make mistakes. There is a code for error. We know this. We all will make mistakes, but we need to be prepared for it, and we need to be ready for it. So this study looked at the comparison of MIS versus open TLIF with regards to clinical improvement, fusion rate, and incidence of major complications, and findings of 14 studies involving MIS TLIF versus TLIF. So they had similar fusion and similar complication rate. However, revision and readmission rates were attributed to deep learning curve. What was happening? They didn't have proper instrument to reduce, and they didn't have enough experience how to reduce patients. So they were put in a cage, but not able to compress properly, not able to bring the thing together, not able to prepare the end plates as good as they would do in an open procedure. So they observed the MIS TLIF surgeons require extensive training, experience is necessary. Otherwise, it may yield unsatisfactory results for your patients. So some studies have documented comparative long-term outcome for open versus MIS spinal operation. So is this learning curve really worth it? So let's have a look at it. So initial cases, if you look at it, open versus MIS surgeries, So same kind of complications in both. So as time passed and you were doing more and more cases, so the difference between open and MIS is a huge difference over time. And the major complications of dural tear, etc., goes down. The biggest advantage of MIS was seen with infection. The infection rate goes down from 5% in some cases to less than 1 in 600. So which is a huge thing that considering the amount of antibiotics and rest and agony patient goes through if they develop infection. So is it worth it? Should I move from a traditional procedure with fewer complications to a relative new procedure with higher complications during the initial early cases and increase operating time? And the answer is yes. Clearly, you want to be giving the best possible to your patients. And now patients are demanding. They would like to have it the minimally invasive, if at all possible, if you think you can give good results. So we looked at this and we concluded that MIS preserved natural anatomy and decreased perioperative blood loss, tissue trauma, pain, and instability. It has a shallow learning curve with multiple contributing factors. Learning curve is usually achieved by 35 MIS cases with significant decrease in complications and operative time. So we looked at all these different factors in our study, in which we showed that according to patient surgeon factors, proficiency of the surgeon, knowledge of anatomy, 3D understandings, surgical aptitude, manual dexterity, frequency of surgeries, what they were doing. Progressive training, starting structured, concept via 3D computer, cadaver, under supervision, and then independent. Procedure, start from injections, go on to interlaminar disc, to transfemoral disc, to TLIF, to ALIF, and OLIF. And hospital obviously needs to provide appropriate equipment, train the team, scrub nurse should be trained, radiographer needs to be trained, and you need to have technical support if something goes wrong. So this is the whole complex. If you had all this and you're at this stage, then obviously you're good to go. So you may have a plan that you want to go on a bike from point A to point B, but the reality is that you can have valleys, you can have problems, you can have fire in between water, and weather may play a part. So all this, you need to be prepared that this procedure may have X, Y, Z complication, and I need to be prepared for it. My anesthetist may be giving high blood pressure to the patient, and that may be causing some bleeding. I don't know. So there are many things you need to look at, or your assistant by mistake causes a problem. So all this you need to be really ready for. And if you're ready for it, obviously your learning curve is there and you should be able to have reasonable outcome. So complications associated with initial learning curve of MIS surgery, the systemic review, they looked at 14 cases or 966 MIS procedures that include MIS TLIF, and they found the most common complications were durotomies. For fusion, complications include implant malposition because they were not able to reduce or compress properly. Instrument-related neural injury was possible in non-union. So total complication rate was 11%, which was nearly the same for an open procedure itself. So average of 20 to 30 cases were warranted for TLIF, according to our friend, which was published in 2014. And there were satisfactory results for TLIF, MIS pedicle screws, MIS ALIF, and MIS cervical surgery. Learning curve for MIS TLIF, so is anywhere from 10 to 44 cases, but by 10 cases, you should be pretty all right. You could be an average surgeon, but after 44 cases, you need to be an expert at that stage. So in conclusion, surgical aptitude, manual dexterity of the trainee, and structured training are important factors in reducing the learning curve. Facilities for training and practice of surgical techniques have enormous impacts on the learning curve, and training on inanimate trainers and animal tissue is vital to improve the results. So this gentleman, he needs to know what he needs to do. So if you are going to do this, you're going to get a kick. So you need to be prepared how you're going to go about it. So if you're prepared, you are not going to have this fate. This is K2 with Baltor Glacier. This is an amazing part of the world, and you need to come here sometime once COVID is over and visit this. Hikers have really pleased. We recently had a dozen Nepali guys who came and who, for the first time in winter, went to the top of K2, which is amazing. We, as World Spinal Column Society, I'm the president of the society. We have Meet the Experts, and this is coming up in near future, next weekend. So you guys are most welcome. And World Spine is coming out with the Virtual Spine Congress directly from the OR, and which is run by our course directors, Zia Gokulson from Brown and Lily from Cleveland Clinic, who are joining us. All the young guys are most welcome. I'm grateful and thank you very much.
Yes, thank you, Dr. Sharif, Professor Sharif. Yeah, I don't see any questions in our chat, but I think it is not really a big problem. As then you have explained everything correctly. And I want to say that personally for me, it is a really difficult topic. It's something that, especially minimally invasive surgery in the like spinal cord procedures, it's something like any problems with spinal cord is in the future, that's something with which I should deal like a neurologist. So if the neurosurgeon does a great procedure, then for us it will be like easier work. So I really wish that everyone can be really professional in that first stage. So for us, patients may come in the best like outcomes they could. So I really wish this, and I hope that these lectures also will help neurosurgeons to master their techniques and to dig deeper into this. So like it would be really, really great. So thank you for your lecture. Thank you for found time for us. I'm sure you are really busy. So like. And yeah, it's really a pleasure to listen to you.
Salman, it's possible to say something? Yeah. Congratulate really for your excellent presentation. That's a very, very important topic to take in mind, because for some neurosurgeons not so old than me, for example, it's very important, because I learned to operate lumbar disc herniation and all of the spinal pathology like the traditional approach. I remember in our country to introduce the microscope, for example, was a really revolution. And then actually we try to do in a small approaches with the microscope. I am a neurondoscopist also, but I never try. Perhaps I think I must to learn a lot about this kind of approaches. But it's very interesting. I think it's a future for the young, mainly for the young neurosurgeons.
Totally agree.
In spine surgery is actually, I think, the worst subject in neurosurgery, because we have all of the legal aspects, mainly for the problems with, if you compare, if one patient is operated by the traditional way, not is better for the minimal invasive procedure and so on. So it's very difficult to understand if it's possible to replace actually all of the traditional approaches through the minimal invasive. What do you think about this? Perhaps actually is possible, or perhaps in the future?
I think, we have written a couple of papers just on this, that is the gold standard, microdiscectomy is still the gold standard, or shall we be using these endoscopic approaches or MIS approaches or tubular approaches? Clearly, recently it's been shown that the results are obviously better if you are going to be doing minimally invasive. But if an inexperienced surgeon is doing those procedures, then obviously their results will not be as better. So it takes time to get to that level, and that usually takes 3 to 4 months to get those numbers. And in a big unit, you probably take 6 weeks to get to those numbers. So I think it's possible for even all age group to start these kinds of surgeries and have good results. Young people are more good at it because they play a lot of video games. They have a lot of access to all these things, and they're messing around anyway with the computer all the time. So they're very good at it, and they're able to do things very, very sharply. So I know for a fact that my guys who play regular video games have got much better sense for people who do not play video games, for example. So I think it is possible for old guys to change to MIS approaches quite easily, because it doesn't take a long time. If you think you can give same results as long as you can tell your patient that, yes, there is an option available, but I'm going to be doing open procedure, that's fine. And I think in some cases, some young surgeons may not be doing justice to the procedures because they don't understand that, there are implications of giving a complication to a patient. That when you're young, you just want to get on and do a procedure, it may be difficult and it may not be suitable for MIS. So when you're starting out, you have to start out from injections, then move on to discectomy, and then to transfemoral approach, and then to TLF, etc. You can go on doing those things, but there's a clear learning curve, and you need to follow those rules, which I showed in the thing, and it's also published in the literature. So you can go and have a look at it, and it's important that you understand that before those 10, 12 cases, you'll not get anywhere. Even for experienced surgeons, it takes about 10 to 12 cases to understand, because anatomy is completely different, because you don't have a feel. Everything is done via radiology. So you're looking at an image intensifier instead of looking at looking at a microscope and also feeling with the instrument. So we don't have that instrument feel. It's like doing endoscopy that in brain, where you don't have the feel. Compared to when you're doing microscopic surgery.
Exactly, that's true. That is very important to take in mind, I think. The other thing is one of your best slides was the child in bicycle to reach the final point of the trajectory, because I feel actually neurosurgery is like a war. Your enemy is waiting for you. This is the reason, and mainly in spine, because spine, you try to treat perhaps 1 or 2 levels, but you have a lot of levels with problems with spinal arthrosis and so on, and it's very difficult to solve all of the things. I have in the last 3 months 2 very difficult cases. I tried to decompress from posterior part of the cervical spine, one colleague, one medical doctor, and develop a spinal white cord syndrome. Was very difficult, really not to wait this kind of complication after the operation. The operation is very difficult, but he developed this motor deficit with quadriparesia and a lot of things. And the other was a very old lady with a spinal compression, this severe arthrosis in the spinal lumbosacral spine, and was also develop a compression after the operation. So it's not so easy sometimes to solve all of the levels of the compression. But
I agree. Yeah,
it's very difficult.
I think regarding anybody who's got myelopathy and we are operating, majority of the time, if you do neuromonitoring, you'd find that the problem is not the surgeon. Actually, the problem is blood pressure. So we treat every myelopathic patient anywhere, myelopathy in the cervical or conus or in dorsal spine. We treat them as a spinal cord injury. So we keep the MAP, mean arterial pressure, up above 85 in those patients. And if you do that, you will see that if you're monitoring, your lines would never drop. On the other hand, if your anesthetist is reading his newspaper or looking at news or playing a game on his cell phone and doesn't look at MAP, then you can have serious problems. So in our hospital, we are very particular. So all cases in which cervical dorsal we are operating, we are very, very particular that anesthetist knows what we want the blood pressure to be. And if it comes down, we stop surgery. They say, okay, the blood pressure MAP is not there, we stop. Because we have shown that if you take care of that, then the chances of causing a problem is very negligible. It's not there actually. So all the main big surgeries all over the world have shown with neuromonitoring that majority of the time, the problem is not the surgeon, but the blood pressure that has come down for various reasons. That happens once the patient is asleep. But that's what anesthetists are there for, and they are good. They should be able to bring the MAP up. And that's where you can avoid those complications. So again, it comes from if you're doing lots of these and your anesthetist is good at it, then it's possible that we could prevent complications like that.
That's true. Thank you so much, Salman. It was fantastic, your
pleasure
speech.
Seeing you again.
Yes, and we learn a lot about that. We must learn a lot.
Brilliant. It's brilliant having you.
Okay, Natalia, if you have some questions perhaps for the audience or not, we are
No, I don't see any questions in our chat, unfortunately. But I think like if we finished, we are still live, so we can discuss something if we have something to discuss, or we can turn off the live and maybe your Professor Sharif like to talk to Dr. Cordova. So like.
Perfect. We have not a question. We have another lecture in 30 minutes.
Yes, in
That's
20.
Yeah,
in
is that
23
Nicolai?
Nicolette,
Yeah.
perfect.
Yeah.
Like
so,
we can actually.
Sorry,
Yeah,
go on.
I'm
Go
sorry.
on. Sorry, go
I
on.
mean,
We're
we
listening.
can finish for now and then go live again like in 23 minutes. So we will not wait
Perfect.
live now.
No problem for me.
Okay.
I wait here. Thank
Alvaro,
you so
it
much.
was really my pleasure. Both of you, you did a great job. I think Natalia, you were all brilliant. I really enjoyed this and give my love and regards to the whole family. They're like family to us. I think over time, we conducted 105 webinars from Pakistan Society. And the funny thing is 30% of people who contributed and participated were from South America. So it was really rewarding for us.
I'm from Ukraine. I'm not from South America.
Okay, brilliant. So we had people from that region, huge people. So when we looked at, there were people from 152 countries that would participate in majority of our webinars. So we had about 37,000 people who participated in those 102 webinars with 150 experts participating. So we had really great time. We learned loads.
In those difficult times, you as a lot of other doctors managed to use it wisely and create this distance learning in a great way. So that's really nice to know that we can actually deal with this situation due to the technologies.
Yeah, I think it's very good. Brilliant.
Yeah. Thank you a lot as well. Thank you, everyone. So we will see our auditorium in 20 minutes with Professor Nicolai Kiev. So thank you.
Okay, Alvaro. Thank you, Natalia. Thank you, Akar. It was a pleasure having you and meeting you all. So good luck. Take care. Okay.
Bye bye.
Take care, Alvaro. We'll meet later.
Bye bye. See you later. Bye bye.
Okay, bye.
So Professor Cordoba, you will join with us as the next lecture too, yes?
Yes, perfect. In 20 minutes, perhaps it's okay. I will perfect. I will reconnect. Okay.
Yeah, sure. Everyone will reconnect. So take your time.
See you in a few minutes.
Yeah, thank you.
Oigan, chicos, ya se acabó en YouTube.
Voy, checo.